Chapter Chapter 23, Behavioral Health Emergencies. Introduction. EMTs often care for patients experiencing behavioral health emergencies. A crisis may be the result of acute medical situation. It can be related to mental illness. It can be the patient took a mind altering substance or substances. It can be attributed to stress, and there can be other causes. Myth and reality. At some point, most people experience an emotional crisis. This does not mean that everyone will develop mental illness. Do not jump to conclusions. The most common misconception is that if you are feeling bad or depressed, you must be sick. There are many justifiable reasons for someone to feel depressed. It can be divorce, it can be the death of a relative or friend. So it can be due to divorce, or it can be due to the death of a relative or friend. It doesn't necessarily mean that the patient is sick. Still on myth and reality, some people believe that all individuals with mental health disorders are dangerous, violent, or unmanageable. The reality is, majority of the patients who have mental health disorders are not violent. Only a small percentage is. However, the small percentage that is violent is usually going to interact with EMS responders in the field. So only a small percentage fall into these categories. EMTs may be exposed to a higher proportion of violent patients. Communication is important. You may be able to predict violence. Now, looking specifically at a behavioral crisis. A behavior is what you can see of a person's response to the environment, and it is based on his or her actions. Over time, people learn to adapt to stress. Sometimes stress is so great that the normal ways of coping do not work. Reactions to stress that are acute and those that develop over time can create a crisis. So the inability of a person to adjust to stress can lead to a behavioral crisis. A behavioral crisis includes patients who exhibit agitated, violent, or uncooperative behavior, or who are a danger to themselves or others. If an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern. When a behavioral health emergency arises, the patient may show agitation or violence. They may become a threat to themselves or others. This is where medical intervention may be necessary. The magnitude of mental health disorders. Mental disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. Anxiety disorders are among the most common. Anxiety disorders include general anxiety disorders, panic attack, social and other phobias, post-traumatic stress disorder, obsessive compulsive disorder. The U.S. mental health system provides many levels of assistance. This includes professional counselors who are available for marital conflict and parenting issues. More serious issues are often handled by psychologists, and severe psychological conditions will require a psychiatrist. Psychologists observe behavioral patterns. Psychiatrists can write prescriptions to treat certain psychological or mental disorders. The U.S. mental health system provides many levels of assistance. Most psychological disorders can be handled through outpatient visits. Some people require hospitalization in specialized behavioral health units. Behavioral health disorders have many underlying causes. It can be social or situational stress. It can be diseases such as schizophrenia, which affects how a person think, feel, and behave. It can be physical illnesses such as diabetic emergencies. It can be chemical problems such as alcohol or drug use. It can be due to biological disturbances such as electrolyte imbalances or abnormalities. Pathophysiology. An EMT is not responsible for diagnosing the underlying cause of a behavioral crisis or emergency. You should understand two basic categories of diagnosis a physician will use. It can be organic or functional. If it's an organic disorder, it means that it can be linked to a brain function or it can be linked to an area of the brain. Physical damage. For functional disorders, the disorder cannot be linked to any abnormalities in brain structure or function. Organic disorders. Organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in physical or psychological functioning of the brain tissue. Causes include sudden illness, traumatic brain injury, seizure disorders, drug or alcohol abuse, overdose, or withdrawal and disease of the brain. Organic disorders. Organic disorders can lead to altered mental state. Continuing with organic disorders, altered mental status can arise from hypoglycemia, hypoxia, impaired cerebral blood flow, hyperthermia, or hypothermia. All of these conditions can affect how the brain functions. Organic disorders. Functional disorders. Functional disorders, physiologic disorder that impair bodily functions when the body seems to be structurally normal. Examples, schizophrenia, anxiety conditions, and depression. Now, safe approach to a behavioral crisis. One of the most important things that we need to ensure as EMS responders when responding to behavioral crisis emergencies is that we ensure our personal safety and the safety of our crew members. That's going to be very important in these situations. All regular EMT skills are used in a behavioral crisis. When working with a potentially volatile patient, position yourself at a 45-degree angle, but be aware this position could hinder your movement. So don't square up with these patients. Try not to stay within a range where they can grab or hit you. Scene size up. So let's look at the patient assessment for these patients, starting with the scene size up. Scene safety in this situation, potentially dangerous. Is the situation potentially dangerous for you and your partner? Do you need immediate law enforcement backup? Should you stage until law enforcement personnel have secured the scene? These are questions to consider. These are questions to answer. Does the patient behavior seem typical or normal for the circumstances? Are there legal issues involved? Crime scene, consent, refusal. Take standard precautions and request additional resources early. Consider the mechanism of injury or nature of illness. Determine the mechanism of injury and the nature of illness. Note any medications or substances that may contribute to the complaint or be treatment of a relevant medical condition. After your scene size up, the next phase is the primary assessment. Form a general impression. Begin your assessment from the doorway or from a distance. Perform a rapid physical exam. Observe the patient closely using the AVPU scale to check for alertness. Establish a rapport with the patient. Most medical or trauma situations will include a behavioral component. Assess airway and breathing and manage accordingly. So assess the airway to make sure it is patent and adequate. Evaluate the patient's breathing, use pulse oximetry if available, provide the appropriate interventions. For circulation, assess pulse rate, quality, and rhythm. Evaluate for the presence of shock and bleeding. Evaluate skin color, temperature, and cap refill or capillary refill. After the ABCs, what is your patient's GCS? At this point, you can check pupil reaction. Is it a load and go patient? Is it a stay and play situation? Does the patient require a rapid scan or focus assessment? Do you need to consider physical restraints? So transport decision. Unless the patient is unstable from a medical problem or trauma, prepare to spend time with the patient. Next phase after the primary assessment is history taking. Investigate the chief complaint and obtain a sample history. Consider 4 major areas as contributors. Is the patient's central nervous system functioning properly? Are there hallucinogens or other drugs or alcohol involved? And hallucinogens will cause hallucinations, which basically the patient is seeing things or hearing things that are not there. Are significant life changes, symptoms, or illnesses involved? Is there a history of behavioral health illness? Sample history. You may be able to elicit information that would be helpful to the hospital. In geriatric patients, consider Alzheimer's disease and dementia. We will go more in depth in these diseases when we cover geriatric emergencies. Use reflective listening. Now, table 23-2, questions to ask in evaluating a mental health disorder. When you're going through the lecture and studying, make sure you pay attention to this table. After the history taking, the next phase is secondary assessment, physical examination. In an unconscious patient, begin with a physical exam. A conscious patient may not respond to your questions. You can tell a lot about a patient's emotional state from their facial expression, pulse rate, respiration. However, some patients may have a flat affect, like patients with schizophrenia, which basically means they don't show facial expressions. A blank gaze or rapidly moving eyes could mean central nervous system dysfunction. Transport decision. Have law enforcement or firefighters accompany you if possible. There may be a specific facility to which patients with behavioral health emergencies are transported. Transport by ground, make the patient comfortable. After the secondary assessment, the next phase is the reassessment. Never let your guard down if restraints are necessary. Reassess and document every 5 minutes. If we must restrain, 5 persons are required. Shouldn't be less than 5. Can be more, but not less than 5. Someone to control the head, someone to control the left and right arm, someone to control the left and right leg. Once the patient has been restrained physically, monitor the respiration, monitor pulse, motor, and sensory function in all restrained extremities. Intervention. Diffuse and control the situation. The best treatment may be to be a good listener. Intervene only as much as it takes to accomplish task. If you think a pharmacologic restraint is necessary, request ALS as early as possible because ALS would be responsible for giving the chemical or pharmacologic restraint. We will do the necessary communication and documentation in reassessment, give the receiving hospital advance warning of a behavioral health emergency, document thoroughly and carefully. If restraints are used, say which types and why they were used. Now let's look at some specific condition. Acute psychosis. Psychosis means the patient is completely detached from reality. So they are out of touch with reality. Psychosis is a state of delusion in which the person is out of touch with reality. Causes include mind-altering substances, can be intense stress, delusional disorders where the patient has grand ideas that are not grounded by facts or reality, can be schizophrenia, which is a severe mental disorder that affects how a person thinks, feel, and behave. Schizophrenia is a complex disorder that is not easily defined or treated. Typical onset occurs during adulthood. Influences thought to contribute to schizophrenia include brain damage, genetics, psychological, and social influences. Now, symptoms of schizophrenia include delusions, hallucinations, seeing or hearing things that are not there, a lack of interest in pleasure, erratic speech. Now, guidelines for dealing with a psychotic patient. Determine if the situation is dangerous, clearly identify yourself, be calm, direct, and straightforward. Maintain an emotional distance. So manage your distance carefully, especially if you're expecting or anticipating aggressive behavior. Don't square up with the patient. Um, don't try not to remain in a position where the patient can grab or hit you if they are being aggressive. Do not argue with the patient, explain what you would like to do, involve people whom the patient trusts, such as family or friends, to gain the patient's cooperation. Excited delirium. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is characterized by restless and irregular physical activity. So these patients can become aggressive, they can become violent. Symptoms of delirium includes hyperactivity, irrational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, dilated pupils. Be calm, be supportive, be empathetic. Approach a patient slowly and respect the patient's personal space. Limit physical contact. Don't leave the patient unattended. Don't leave the patient alone. Use careful interviewing to assess the patient's cognitive function, determine the patient's ability to communicate early, observe the patient's appearance, dress, and personal hygiene. If the patient has overdosed, take all medication bottles or illegal substances to the medical facility. And if a patient overdoses and is exhibiting signs of excited delirium, it is usually because they overdose on some type of stimulant or hallucinogen. Transport the patient to a hospital with behavioral health facilities. Refrain from using lights and sirens, can trigger seizures in these patients. If the patient agitation continues, request ALS assistance so chemical restraint can be considered. And excited delirium can put a lot of stress on the patient's heart, so they are at risk for sudden death or cardiac arrest. Restraint. Every pre-hospital care transport provider should create and follow a pre-hospital patient restraint protocol. Protocols vary throughout the country. The restraint chosen should be least restrictive that ensures the safety of the patient and providers. We don't want to hurt the patient, even though we're restraining them. Personnel must be properly trained. If you restrain a person without authority in a non-emergency situation, you expose yourself to a possible lawsuit. You can be taken to court for assault, battery, false imprisonment, violation of civil rights. You may use restraints only to protect yourself or others from bodily harm, or to prevent the patient from injuring himself or herself. Still on restraints, involve law enforcement if the patient is in a severe behavioral crisis or behavioral health emergency. Before considering physical restraint, use verbal de-escalation techniques. Now, the process of restraining a patient. Carry out the decision quickly. There should be no less than 5 people to help, can be more but not less. 1 for each extremity and 1 for the head. And when controlling the extremity, joint control is important. We want to eliminate the possibility of the patient being able to flex and extend the arms and legs. There should be a team leader and a plan of action. Use the minimum force necessary. The level of force will vary depending on these factors. The degree of force that is necessary to keep the patient from injuring yourself and others. the patient's sex, size, strength, and mental status, the type of abnormal behavior the patient is exhibiting. Talk to the patient throughout the process. Treat the patient with dignity and respect. If possible, a provider of the same gender should attend to the patient where appropriate barrier protection. Avoid direct eye contact and respect the person's personal space. Never leave a restrained person unattended. 4-point restraints, both arms, both legs are preferred. Monitor the patient once restrained for vomiting, airway obstruction, respiratory status, circulatory status, blood pressure, changes in level of consciousness. So constantly monitor these things. The potentially violent patient. Violent patients account for only a small percentage of patients undergoing a behavioral crisis. Pay attention to their history. So, has the patient previously exhibited hostile behavior or overly aggressive or violent behavior? Pay attention to the patient's posture. How is the patient sitting or standing? How are they moving in their environment? How are they interacting with their environment? Is the patient tense, rigid, or sitting on the edge of his or her seat? Pay attention to the scene. Is the patient holding or near potentially lethal objects? Pay attention to the patient's vocal activity. What kind of speech is the patient using? Is it loud? Is it obscene? Is it erratic and bizarre speech patterns? Which this will usually indicate emotional distress. Physical activity. This is the most telling factor of all. A patient requiring careful watching is one who has tense muscles, clenched fists, or glaring eyes, is pacing back and forth, cannot sit still, is fiercely protecting their personal space. Other factors to consider for your potentially violent patient. Poor impulse control. Does the patient exhibit that? Is there a history of truancy, fighting, and uncontrollable temper? Is there a history of substance abuse? Is the patient suffering from depression? Is there a functional disorder present? Suicide. Depression is the single most significant factor that contributes to suicide. It is a common misconception that people who threaten suicide will never commit it. Suicide is a cry for help. Someone is in a crisis that he or she cannot handle alone. Immediate interventions are necessary or is necessary. Be alert to these warning signs for suicide. Is there an air of tearfulness, sadness, deep despair, or hopelessness? Does the patient avoid eye contact, speak slowly, and project a sense of vacancy? Is the individual unable to talk about the future? Is there a suggestion of suicide? Have they made plans related to death? Table 23-3 has the risk factors associated with suicide. Once time allows, give this table, make sure you spend some time and look at this table. Consider these additional risks. Are there any unsafe objects nearby? Is the environment unsafe? Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? Additional risks to consider. Is there an underlying Medical problem. Are there cultural or religious beliefs promoting suicide? Has there been any trauma? A suicidal patient may be homicidal. Be very careful around these patients. Post-traumatic stress disorder and returning combat veterans. PTSD occurs after exposure to or injury from a traumatic event. The patient keep reliving the event and it affects how they function in everyday life. It can develop as early as 3 months after the event or as late as years after. However, for the person to be diagnosed with PTSD, they have to be exhibiting the signs and symptoms for over a month, for over 1 to 2 months. Now, examples of events that can trigger PTSD: sexual and physical assault, child abuse, serious accidents, natural disasters, war, loss of a loved one, stressful life changes. Not necessarily the result of one event, so it might not be linked to just one event. It can be more than one events that cause the PTSD. An estimated 7 to 8% of the general population will experience PTSD at some point in their lives. It's very common for military personnel who have experienced combat. Symptoms of PTSD include feelings of hopelessness, anxiety, anger, fear. People with PTSD frequently avoid reminders of trauma, loud noises or smells, and interactions with people. They suffer from constant nervous system arousal, so their nervous system is triggered easily, can relieve the traumatic event through, can relive the traumatic event through thoughts, nightmares, and flashbacks. Combat veterans are prone to early heart disease, higher incidence of type 2 diabetes, loss of brain gray matter, and higher incidence of traumatic brain injury or TBI. Caring for the combat veteran requires a unique level of understanding. Be careful how you phrase your questions, use a calm, firm voice, but be in charge, respect a veteran's personal space, limit the number of people involved, ask about suicidal intentions. Caring for the combat veteran. Ensure that there is nothing the patient can access and use as a weapon. Physical restraints may simply escalate the problem. So avoid them unless it's absolutely necessary. Medical legal considerations. The medical legal aspects of EMS are more complicated with patients undergoing behavioral health emergencies. Legal problems are reduced when the patient consents to care. You must decide whether the patient needs immediate emergency medical care. The patient may resist your attempt to provide care. Never leave the patient alone. Request law enforcement personnel to handle the patient. Consent. Implied consent is assumed with a patient who is not mentally competent to grant consent. Consent matters are not always clear-cut in behavioral health emergencies. If you are not sure, request assistance from law enforcement or seek guidance from medical control or your medical director. Limited legal authority. The EMT has limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists, competent adults have the right to refuse care. And that, well, yes. So once they can understand what's going on and they understand the repercussions of not getting the care that is required, they can refuse. In psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent. Maintain a high index of suspicion about the patient's condition and err on the side of treatment and transport. That would bring us to the end of this chapter.